Hello.
Hey, Dr. Brown.
Hey, can you guys hear me?
Yeah. Good to go.
Okay, good. Thanks for joining, everyone. What may be useful to give people one more minute is I know people have their cameras turned off, but if you want to turn on your camera, or if you don't and you just want to say your name and your role, so we can get a feel for who's on the call and kind of get to know each other a little bit. I'll start, and then Melissa, I'll ask you to go next, and then we'll make our way around. I'm Whitney Brown. I'm one of the advanced lung disease and lung transplant physicians here, and I am the director of the adult cystic fibrosis program. So that's so CF and lung transplant is mainly what I do, both inpatient and outpatient. Melissa?
Hi, everyone. I'm Melissa Bowen. I'm my main position is the CF coordinator, the one and only the nurse coordinator. And then I also take care of and kind of cross cover advanced lung disease and lung transplant patients as needed. So thanks for everybody attending, and looking forward to this.
Dr. Single?
Sorry. Hey, my name's Anju Singhal. I'm also with the ALD team and will be staying on. I'm interested in cystic fibrosis. I'm actually covering a shift in the ICU today, but I wanted to listen in and say hi.
Thanks, Anju. David? Thanks for joining last minute.
Sure. Hi, I'm David. I'm an infectious disease pharmacy specialist.
Thank you. We come to David for advice on our most challenging cases, usually inpatient, but I've tapped him for outpatient cases too. Michelle, you want to introduce yourself?
Hi, I'm Michelle. I'm the post-lung transplant nurse.
Thank you. All right, Dr. Donaldson.
Hello, everyone. I'm Sahoy. I'm one of the rotating Howard Fellows.
Okay, and next we have Astrid, or Juliet, or Jet, we call her. She's our educational all things education and CME coordinator. I don't know if she wants to wave.
Hi, everyone. Thanks, Dr. Brown. I'm Juliet Munoz, and I work with the advanced lung disease and transplant program as a educational program manager. And I'm here recording this meeting for our website, for our lectures website.
Okay.
Thank you, Dr. Brown.
Thank you. Carlin.
Hi, good afternoon. My name is Carlin Ng, and I am the pharmacy manager at the Inova outpatient pharmacy at the Fairfax campus.
Awesome. Is that over all of the different outpatient pharmacies, like the
I'm
hospital?
just IHVI.
Oh, IHVI. Okay. Awesome. Michaela?
Hi, everyone. My name is Michaela, and I'm a clinical pharmacist that works with Shields Health Solutions.
Awesome. Thanks for joining. Zarna.
Hi, everyone. My name is Zarna, and I'm also a clinical pharmacist with Shields.
With Shields. Great. Miriam?
Hi, I'm Miriam Morkel. I'm the pharmacy manager at the outpatient pharmacy at Shore Cancer Institute.
Awesome. Okay. What about Sarah?
Yes. Hi, everyone. I'm Sarah. I'm the regional supervisor of clinical pharmacists for the group here at Shields.
Great. Stella?
Hi, everyone. My name is Stella. I'm one of the clinical pharmacists here with Shields.
That's great. Can I just ask one question to clarify? Tell us how Shields and Shar interact, or kind of, I know you guys are the specialty pharmacy.
Yeah, we're a group of specialty pharmacists that help support patients that fill with the Inova specialty pharmacy. So we kind of do like counseling, follow-ups, and we just, follow those patients that fill with the pharmacy here.
Okay, thank you. Okay, Rebecca.
Hi, I'm one of the clinical pharmacists with Shields as well.
Thank you, welcome. Matt?
Yes, Matt, another clinical pharmacist from Shields.
You guys got a good showing today. Thank you so much. I don't know, Gil, G-I-L, it's probably short for something.
Hey, Dr. Brown, it's Gloria.
Oh, Gloria.
They
Yeah.
have it weird with Zoom. Anyway, I'm the pharmacy liaison with Shields, and I'm in the Heart and Lung Transplant Center, but I also do some CF and some here too.
Yes, we know Gloria by name. We liaison with her. She gets our drugs covered. Thank you, Gloria. Carly.
I don't know if you guys, but I'm another one of the pharmacists.
Great, thanks for joining. Jordan?
Hi, my name is Jordan. I'm also one of the clinical pharmacists for Shields.
Great. The next one I think is another abbreviation, ORGESA.
Hi, this is Orgesa. I'm another clinical pharmacist from Shields.
Oh, thank you, Orgesa. The next one, ONGUYEN.
Hi, this is Anna. I'm one of the clinical pharmacists at Shields as well.
Thank you, Anna. I'm sorry if I know I'm going to butcher a name, I'm just going to spell it. So I'm sorry about that. And the last one, the last one is a call-in 571.
That might be me. Hello. This is Zoe. I'm actually the manager of patient services on the liaison side of things. So I work with the Shields pharmacists and Gloria, as well as the Inova pharmacies itself.
Wonderful. Thank you. Sounds like an important job. We got two people joining. I want to thank you. I'll give them a second to join their audio. I want to thank you guys for your flexibility. We moved the date from today or from tomorrow till today because I got a bronchoscopy scheduled right in the middle of the lecture tomorrow. So I figured that's not going to work well for us. So thank you. We're just introducing ourselves for the last two people that joined. Kevin, do you want to just tell us your name and your role?
Hello there. My name's Kevin. I'm a clinical pharmacist at Shields Health Solutions over in the Hartford sector and CCMC.
Welcome. Where is Shields physically located?
In Massachusetts.
Oh.
Yeah, I am physically located in Denver, Colorado.
Wow. So we're getting a nationwide call going on. That's
Yeah,
great.
yeah,
Thank
exactly.
you.
Exactly. Yeah, absolutely. Thank you.
Thanks. And then let's see, Hampt, HAMPTSH. Sorry, I don't have the name. Do you want to introduce yourself?
That might be Shalette, our new advanced lung disease coordinator.
Got it. Welcome, Shalette, if you're there. And then Deborah.
Hey everybody, I'm Deb Brooks. I'm the director of the retail and specialty pharmacies for Inova. Nice to meet you.
Thank you. Nice to meet you. And then I see Omid, Dr. Omid. I think he's a rotating fellow. Omid, do you want to say hi? Not to put you. Hi. And you're from Carillion and Roanoke, right?
Yeah, we were still rounding. Sorry for the delay.
Oh no, thanks to everybody for joining. Now the next challenge, is there anyone who didn't get a chance to say hi? Okay, the next challenge is see if I can share my screen and we can get started. I want to be really casual. I think part of the reason for doing this is we've been working together more, and I think just getting to know each other, faces and names is really helpful, and kind of how things work. And then the other part is just for me to provide a little background on why we're prescribing some of the drugs that we're using, whether it be Trikafta or inhaled antibiotics. So I want to just please interrupt me. I'll be happy if you interrupt me because I don't want to just talk and to hear myself talk. So let's be interactive. And if we don't cover the slides, it doesn't matter. There's no CME credit or anything. So it's just really a dialogue. I'm going to share my screen. Did that work?
Yep, you're good.
Okay. All right. So some of you, this is a little bit of a modification of a recent talk I gave for the International Society of Heart and Lung Transplant, but I tried to make it relevant to kind of what we're doing here at Inova. So So we're talking about cystic fibrosis, and we're an adult team. There is a pediatric team here at under the umbrella of Inova that is called Pediatric Lung and Allergy Center. So they're an outpatient pediatric the pediatric pulmonologists that admit to the Children's Hospital and are sort of our pediatric counterparts. But this really is more designed to for the adult world. Okay, so our objectives, really, I just want to kind of introduce the concept that CF is, if you haven't already gotten a feel for it, CF is a really multidisciplinary, multifaceted approach, and that's because it's a systemic disease. We're of course most interested in the lungs, but you can't do CF without talking about sinuses, the GI tract, lungs, etc. So with that in mind, I put together this nice little Venn diagram that sort of shows like the most important areas to address when we talk about CF care. And one is obviously lung function. And lung function we can kind of put into, these are more therapeutic domains, but lung function we can put into respiratory therapy. So looking at clearing mucus from the lungs, looking at inhaled antibiotics, if we're going to use those, anything, sort of nebulized therapies, airway clearance, and exercise would fall into this domain. Nutritional support. We'll talk about why nutrition and lung function go hand in hand, and why we're so obsessed with making sure people are at a good optimal weight. The one that's been most exciting in the last several years, but really since October, was that October of 2019, Melissa?
Yes.
Is the highly effective CFTR modulator therapy. So Trikafta specifically is the brand name. The generic is Elexacaftor, Tezacaftor, Ivacaftor. So I'll call it ETI. And that's really become a critical part of care for about 90% of patients with CF now. Not everybody, but most people at this point. And then lastly, David's favorite topic, antimicrobial therapy. So knowing that these patients have long-term infections that many times we can't eradicate, but we need to treat over time when they get sick. Maybe in the future we'll be able to eradicate in some cases if we start early enough and lung function is good enough. So that's kind of a way to conceive of CF care. But we'll start with the nutritional part of the Venn diagram. And this is a very well-known graph in the CF world where it looks at lung function. So over here on the y-axis is lung function, and we measure that by FEV1, and that stands for forced expiratory volume in 1 second. So we have patients, take a big inhale in and blow out as hard as they can. That's what spirometry is. And how much they can blow out in that first second of their breath gives us an idea of how obstructed or not or normal their airways are. So if we look at this over time, so 80% and higher is normal. So what we see is if you graph lung function and you graph body mass index, there is a very proportional relationship that as lung function improves, usually nutritional status improves and vice versa. And it's not a true cause and effect, but there's it's so intertwined here that we have to pay attention to both. And you can see when the curve starts to kind of flatten out, there's a law of diminishing returns. Obviously, it's not helpful for lung function if people become obese, but the magic number is kind of right here at the top of the curve where we derive our goal body mass index for women. Adult women is 22, and for men is 23. So that's what we're going for, and why we're interested in weight. And this is a picture of one of our lung transplant recipients weighing in at the beginning of her clinic. So it's not just a matter of calories in and calories out. In CF, because it is a multi-organ system disease, there's pancreatic involvement, stomach involvement. We actually have to look beyond just the calories and look at what all the different components that go into gaining weight. And so we have to look at if people have a normal appetite. We know that people with CF have very high metabolic demands, and so that requires more calories than a normal diet. So that's part of it. But looking at appetite, sometimes using appetite stimulants if we need to. And then there's a lot of GI issues that kind of go into not wanting to eat as much or not being able to gain weight. And so when people have poorly controlled reflux, if they have gastroparesis, where their stomach doesn't empty normally and their food sits for hours and they still feel full by the time they go to try to eat, and then they can eat all the calories that they want, but if they're not absorbing the fat content of their meals because of fat malabsorption, then they're wasting a lot of what they're taking in. So on the right side, since you guys are primarily pharmacists, this is kind of the pharmacologic response to when we identify these problems. So our goal is kind of to ask about all of these things, and then how the intervention is how we might respond. The last two are, chronic constipation is a problem in CF, because if you think about CF as the problem with CF is something called CFTR. So the CF transmembrane regulator. So it's a chloride channel that maintains salt and water balance all over the body. And so it does not, so when there are two mutations for CF, it's autosomal recessive. When there are two mutations, the chloride channels do not work at the normal level, and then you end up with thick, dehydrated secretions all over the body. And when that happens in the intestines, then that can become chronic constipation, or something that we actually call DIOS, distal intestinal obstruction syndrome. So that's kind of the extreme situation where there's actually a mucus stool plug in the intestines, and classically it's in the right lower quadrant, but where it actually gets blocked up and people get nausea, they get pain, it almost can go all the way to a small bowel obstruction. So obviously if this is a problem, people are not going to eat and gain weight. And so we use osmotic laxatives like Miralax and Go Lightly to try to unblock that. And then and a lot of hydration. And then lastly, about 30% of adults with CF due to pancreas issues have hyperglycemia, and then that can be treated with, we don't usually restrict diet, we prefer just to use insulin. Any questions right now before we move to the next domain? Next is we're going to move to the lungs. And so we talked about sticky, thick secretions all over the body. So now in our pulmonology world, this is where lung function gets compromised, is where the mucus in the lungs is sticky, dehydrated, thick, and that leads to chronic infections. So bacteria love warm, sticky places, and so they hide in mucus, and and after they've been there a while, the classic bacteria is Pseudomonas. After it's been there a while, it almost lives in like a biofilm. You can picture like algae, a layer of slime or algae that just, the lungs are overtaken with infection. And part of what we ask patients to do each day is to spend time and energy clearing the mucus from their lungs. So these are the mechanical devices that we use. You guys have probably seen acapella or flutter valves. Patients wear a vest that vibrates on their chest to loosen up their mucus. Many times family members or loved ones actually, can pound on people's backs or their sides to loosen up mucus in focal areas. There's like it looks like a massager, but it's actually, again, designed to loosen up mucus. It's a percussion, handheld percussion. And then there's also ways to provide a little vibration while people are doing nebulizer treatments, and that's a IPV, which is usually just used in the hospital. And then the last one that actually is not used very much in CF is a cough assist device. This is a machine that strengthens the robustness of someone's cough. That's more, usually people with CF have a very strong cough and they rely on their very strong cough to help clear mucus. But in cases where like muscular weakness, like ALS or muscular dystrophy, something like that, they may need, this is another device that can be used. So we use these to clear mucus in addition to, inhaled medicines that help sort of open up the airways like albuterol, and then you have saline and Dornase alpha, which hydrate the mucus to make it easier to move. And then this is the mechanical devices that we use to actually move it up and out, and so that they will cough it out instead of having it kind of be stuck down in their lungs, causing more symptoms and more infections. This is a really cool picture one of our patients sent from home, and you can see that this disease is has a high treatment burden, meaning that people spend lots of time, energy, effort, on taking care of themselves. It's not just popping pills. So this is somebody's home respiratory therapy station. So this is actually in his house. He has a chest vest. He has a nebulizer machine here. You can see he's got his, you guys tell me, is this albuterol in those little packs there? I think they're albuterol vials, you know, all of his nebulizer stuff. So this just shows you, you know, it's a really demanding disease, and it's not as easy as just popping pills. And so these patients routinely can spend 3 hours a day on their airway treatments, which usually, typically, if they're well, might be twice a day. And if they're sick, you know, might be 3-4 times a day that they're trying to clear mucus. Along with clearing mucus, we know that exercise is really important. It's kind of a natural way to move mucus. You know, when I always tell patients when they work up a sweat on the outside, they're sweating on the inside. And so they actually brings hydration into their airways to loosen up mucus. And so we're really lucky that we have developed a pulmonary rehabilitation or an exercise program that's designed for people with CF here at the hospital. One of the few programs probably around the country that is really a standalone program. It's in addition to our standard pulmonary rehab program, but we have our wonderful respiratory therapist, Quinn, here, and she's working with one of our patients. We have dedicated gym space one-on-one where they can have their oxygen saturations monitored. You see she's wearing a forehead probe there, heart rate, oxygen monitoring, and then you know, get the cardio and weight training that they need, and as well as education, et cetera, in a safe environment where they're one-on-one. You will notice the yellow gowns and gloves, and that's just to remind us that CF, because of all of the infections that can occur down in the lungs and in the sinuses, everyone with CF is placed on contact isolation here when they're in a hospital setting, and that includes our clinic. So they don't have to, you know, if they're in their room or their treatment room, their clinic room, their treatment room, or their hospital room, they don't wear gowns, but all the healthcare workers that come in, we wear gown and gloves. Of course, now everybody's wearing masks because of COVID, but that's nothing new in CF. People with CF have been wearing masks out in public, and especially in a hospital setting, for years. They have been told to stay 6 feet apart from one another because of infections. And we, by default, put everyone on contact isolation for their protection and for the protection of others. We don't wait and decide what they, you know, decide do they need isolation based on what they grow. It's just a uniform policy, because we never know what they might grow today in clinic that we didn't know about. And this is just a picture of someone, one of our patients who has a tracheostomy with CF, who was exercising right after lung transplant. So again, really important to think of exercise as a way to clear airways and improve lung health. Now we're going to get into the antibiotics. So this is a lot of these graphs that I'm showing you are from the CF patient registry. And because we're an accredited CF center, we enroll patients into a national registry where we put anonymized data about their, you know, about the patients that we follow. So we have about 110 adult patients, and I think we have 105 or 106 that actually have consented to let us submit their information to a registry. And we put in things like their lung function, the bacteria that they grow, their weight, how often they get sick. And so this helps the Cystic Fibrosis Foundation, which is kind of our national patient advocacy and clinical care network. It helps the CF Foundation know what's happening with patients across the country and where to invest money, and, you know, and trends and clinical trends. So every year they generate an annual data report based on centers like ours entering data across the country. And so this is from last year. And based on what we and all the other centers across the country have entered on our patients, they can come up with these pretty graphs. And this graph shows us what bacteria sort of predominate at what age groups. So across the bottom, we can see this is the age for CF patients. And so it goes from age 0 to age 34. Certainly there are people living way beyond 34 now, but this is kind of the cut that they made. And we can see, and the bigger the slice of the pie, the more prevalent the bacteria is in that age range. So we can see that Staph aureus, and this would include both methicillin sensitive staph and methicillin resistant staph, is a big piece of the microbial sort of environment, but it does diminish a little bit as patients get older. What we clearly see is Pseudomonas, sort of originates during adolescence for a lot of people, and then gets to be more prevalent either by itself or along with Staph aureus for our adults. And then there are a host of other usually gram-negative bacteria that we see in smaller quantities, like Stenotrophomonas, Achromobacter, trying to think of other ones, E. coli. And there are, what'd you say, David?
Burkholderia.
Burkholderia, thank you very much.
I feel like I'm surprised when I see this, how small the other is, because I feel like I only get involved when we have these crazy others.
Yes, that's
So
right.
in my view, it's like huge.
Your slice is like tiny down here, but you also get involved with this situation, which is the multi-drug resistant Pseudomonas. And this probably impacts the majority of our adult patients at the center. And what we can see is, again, here's another pretty graph. This is just at raw numbers of individuals with CF and then their age. And this does show us that people are living up to, age 70 with CF now. But what we can see is the Pseudomonas is in blue and the multi-drug resistant Pseudomonas is in red. And so we can see that the multi-drug resistant, I feel like we have a higher prevalence of that here at our center, and that may be because we see sicker patients because we're transplant. But we can see that this sort of peaks in, around age 30, late 20s, early 30s to 40. And that's the prime age when we may need to transplant someone. So we are dealing with how to keep people well and when they get sick, dealing with multi-drug resistant Pseudomonas and how to maintain their lung health. What we know is that the loss of lung function over time in CF over the course of a lifetime is due to what we call pulmonary exacerbations. And what that means is flare-ups of, one of the bacteria that they have down in their lungs will, for whatever reason, it's either triggered by a virus or some vulnerability, and it increases from the already, high quantity of bacteria, say that they have Pseudomonas down in their lungs, they'll get sick, something will change in the airways, either triggered by a virus or whatever, and they'll have more cough and more sputum, they'll lose weight, they'll have a lack of energy, sometimes coughing up blood. And that's how we know that they're sick when they're adults. We don't always get to see the white count, the fever, and the pneumonia on chest x-ray by the time they're adults. It's kind of more burned out. So, being really vigilant about detecting a pulmonary exacerbation is important, because we know that every time someone gets sick with a pulmonary exacerbation, we treat them as aggressively as we can. But if they don't go back to their prior baseline, say they, their lung function started at 60%, and when they were sick, it went down to 50%, and we give them antibiotics, they may not get all the way back up to 60. So now their new baseline is 58. And then the next year they get sick and they drop to 48. And then they recover up to, 50. Anyway, you can see there's a stepwise loss of lung function. So that's why we're really aggressive with antibiotics. And sometimes it may feel, David, that we're I call myself the antithesis of antibiotic stewardship. But, we are, I'm balancing on one hand, not wanting to overuse antibiotics and cause resistance, but also trying to keep people's lung function stable and prevent that loss of lung function over time that's going to drive them towards needing a lung transplant. These are what I call top shelf on the right here. These are kind of strategies we look at using when we have really difficult MDR situations. And this particularly pertains to Pseudomonas. But on the left side, I put kind of approaches that have been used over many years, older strategies that we often turn to, including extended or continuous infusions of beta-lactams, carbapenems, doing the once daily extended interval aminoglycoside dosing, reaching for older, potentially more toxic medicines, but effective, colistin and polymyxin B. And these, these are things that we only do in the hospital, and we only do in consultation with David Allen and his team and our infectious disease doctors. So these are kind of, well, the first two we can do outside of the hospital, but the last two here we would reserve for in hospital use only. These on the right-hand side are newer antibiotics on the scene that we reach for only in desperate times. Don't worry, David, we're not gonna overuse them. But they're new things that we have found helpful in the most difficult to treat situations. And it is nice that there is a pipeline of antibiotics that are being developed over time. Although if you look at, the number of new antibiotics, it doesn't seem, it seems like our resistance outpaces the antibiotics that are available. But so this is kind of when they're sick. Another strategy we use frequently to keep people healthy and prevent the exacerbations is a concept that we call CAT, continuous alternating inhaled antibiotic therapy. And that's where you guys on the outpatient side will see us prescribing inhaled antibiotics in an alternating fashion, like 1 month on atobromycin, and the next month they might switch to aztreonam. And those are inhaled, and they're just trying to keep things in check and keep people from getting sick. Sometimes we use them in combination with oral antibiotics for milder flare-ups, but usually they're more of a preventative long-term strategy. So we'll talk a little bit more about that. And then this is a really cool thing that we will be seeing more of, I think, down the line, that's still investigational at this point, which is bacteriophage therapy. And not to get too much into the weeds, but the basic concept here is when you have multi-drug resistant bacteria, there are viruses that can now be developed to target bacteria. So if you look at this concept of a bacteriophage, so here's the concept. It has a viral RNA or DNA in it, and it basically targets a bacteria, and then it injects its viral genome into the bacteria. And that may result in some direct bacterial killing, but it also may result in changing the defense mechanisms of the bacteria such that they're going to be more susceptible to antibiotics in the future. It sort of takes away some of their defenses against antibiotic, renders them maybe more susceptible. Maybe it downregulates aminoglycoside efflux pumps, or some of the workarounds that the bacteria has come up with. It tries to dismantle those. So I think we'll still very investigational, but they're being used in a nebulized fashion and IV fashion at certain institutions around the country. We have established a relationship with investigators from Yale who have a whole library of bacteriophages, and we were very close to using one for a patient who got sick late last year in the hospital, that we sent a sputum culture up there, and they had a phage that worked against it. But obviously there's a lot of red tape. You have to get permission from the FDA, et cetera. But this is something that we'll see more down the line. The other thing is that they are starting a multi-center bacteriophage cocktail study. And one of the centers is going to be Johns Hopkins, and we may start referring some of our more difficult resistant patients up there to enroll in there. It's an outpatient, and it's a cocktail of phages. So it's not designed based on their individual sputum like the library at Yale. You actually, you try it on a person's sputum, but this is a cocktail of different phages that should work against most people's sputum. And so we'd love to send and enroll some patients in that to have that technology move forward.
Are they all Pseudomonas targeting, or is it a broad spectrum of bugs as well?
Primarily Pseudomonas. There are investigators, I think, at Pitt that are looking at Mycobacterium, and they will, and up at Yale, that you could send them like a difficult Achromobacter, a couple of other gram negatives. They have phages that may work. But I think we just received the inclusion exclusion criteria for the study the phage cocktail study that's going to be hosted at Hopkins, and it was Pseudomonas. But unfortunately, they're limiting it to people with pretty good lung function, FEV1 60% and above. So that's always the problem, is that the sickest patients have the lowest lung function or have had a transplant, and then they're excluded from the trials. So we'll have to, I guess we can, that's where the getting an individual IND may be in the future for some patients. But this, for now, you know, kind of more back to our reality, we're really hoping that the phages will get more experience in the future. But for now, we're looking at, I did want to just expand on that continuous alternating inhaled antibiotic therapy, the CAT therapy. And so the concept here is usually it's targeting Pseudomonas, because that's our most prevalent bug. And so we ask patients to inhale an antibiotic, either one that's nicely packaged and FDA approved, or in many cases, we use things what we call off-label, where patients are actually having to reconstitute the injectable vials, you know, with saline or sterile water, and then put them into their nebulizer. So regardless of whether it's packaged or off-label, we always recommend pre-medicating with albuterol before inhaling an antibiotic, because we do know that people will have cough and people will get some chest tightness if they just go straight to an antibiotic. Usually what people are doing is they're clearing their airways first of mucus. They're doing like albuterol, saline, and then the Dornase alpha, clear the mucus out. And then they're still have the bronchodilator in their system. And then you go in after they're done coughing up the mucus, then we want them to go in and take the inhaled antibiotic last. So it dwells down in the airways for hopefully the next 10 hours until they do their airway clearance again. So that's one thing in terms of teaching. If you guys come across some of our patients, the order in which people clear their airways and then take the inhaled antibiotic or the inhaled steroid, if that's the case, does need to be commented on. And I usually try to ask really open-ended questions in clinic about, tell me the order in which you're doing it. Because if we just say, are you doing airway clearance? They say yes. But I'll say, well, tell me exactly the order. And I just found another patient this morning who was taking their inhaled meropenem before their saline. And so it never ceases to amaze me that the confusion that arises. But logically, I always try to tell patients anything that we want to stay down in the airways, like an inhaled steroid or an inhaled antibiotic, they need to take that after they clear their mucus. They don't want to turn around and cough it up. So for Pseudomonas, the first two, you guys probably have a lot of experience with. Tobramycin was the first inhaled antibiotic that was approved. What you may not be aware of is that all these brands have come on the scene. So initially it was Toby, the brand Toby, T-O-B-I. Now we have another alternate brand named Bethkis, then there's Catabis, there's Tobramycin inhaled solution, and then there's generic Tobramycin. So, and I think Gloria and Jordan have probably figured this out, that when they get a pushback on the insurance for one formulation or the other, there's many that you can try to submit. All of these are through a conventional nebulizer, and they're all twice a day. There is also this Toby Podhaler. I don't know, has anybody worked with Toby Podhaler? I would have to say we don't prescribe, I think they use it more in pediatrics than in adults. What we find is that for our healthier patients with good lung function, they might be able to get away with it, but it's a dry powder inhaler, so you don't need your nebulizer, very portable. And they basically take out a capsule and inhale it, basically crunch the capsule, inhale the powder from it, and it takes 4 capsules each dose. And so it's 4 in the morning, 4 at night. And so it's very, very good for people, high school, college age students. They have to be careful about storing it, not in the extremes of temperature, but it produces a lot of cough, and you have to have good technique in inhaling it. So some patients will try this and just have too much cough. Other people's insurance will deny Podhaler and make them do a nebulized formulation, but we don't prescribe as much as the pediatric group does, and we don't have it on formulary in the hospital either. Just something to think about with tobramycin, it is nephrotoxic. Generally, people with CF have good, healthy kidneys until they have a lung transplant and they're on tacrolimus and other, stressful medications. But after lung transplant, or when there's any kidney disease, I sometimes will check a random tobramycin serum level, because I just want to make sure it's not getting at any measurable amount into their bloodstream. especially if their creatinine starts to go up. So, and in that situation, I don't know, David, what your best advice would be. Sometimes I just do 300 once a day because it's just easier for the patients to not have to get out the nebulizer twice a day. Or you could split the dose in half and do it twice a day. I don't know if there's really a rationale one over the other.
I mean, I'd probably do a larger dose once a day, just since it is a concentration dependent drug, probably better to do bigger doses less frequently.
And I think the patients like that better too, right? Because then they only have to sit down and do it once a day. So Cayston is inhaled as Trianam, another Pseudomonas drug. I don't like IV as Trianam as much for treating exacerbations, but I think the inhaled as Trianam is good over the long term. It is through a special nebulizer called an eFlow. And for what you guys, what's helpful to know here, the technology is called the eFlow. The Gilead that makes Cayston, they call their version that they dispense with Cayston Altera, and they will only give patients one for their lifetime because the retail cost of this special nebulizer is close to $1,000. For that reason, we don't, and maybe for other reasons, we don't have it in the hospital. So patients who want to continue this medicine from home when they're hospitalized, they have to bring both their fancy nebulizer and their medication. But the good news about Cayston is because of this eFlow technology, it's a highly efficient nebulizer. It only takes 3 to 5 minutes to inhale. Whereas the other, the other conventional nebulizer treatments, as you guys know, 15 to 20 minutes usually. So very short inhalation times. It is 3 times a day instead of twice a day. I think many patients do skip doses, even though we encourage them not to. That's just reality. So this is usually a good selling point, the short nebulization time. There's a little bit more cleaning because they end up with 3 handsets per day, but I think most patients like Cayston. And it's also not nephrotoxic, which is nice. And that is, all of these are FDA approved for cystic fibrosis. Colistin is, an oldie but goodie that we use a lot. It does not come nicely packaged, as you guys know. So patients have to reconstitute it. And so there's the full dose I consider nebulized as 150 twice a day. And this is usually the instructions that we give patients. They either dissolve the whole vial with 6 mLs of sterile water, which is usually what we do. Or sometimes if they've had an issue, we'll do 3 mLs of sterile water, 3 mLs of saline. But that gets very complicated, as you can imagine. And then they nebulize it twice a day and it foams. It's kind of like a weird texture and it foams. And sometimes people have more chest tightness with Colistin than other drugs. We can half the dose to 75 twice a day if patients have trouble tolerating it. And then always we ask and make sure that they're taking albuterol first, particularly with Colistin because it will cause chest tightness. Off-label, any other comments, David?
I was gonna say, yeah, the Colistin, I mean, its mechanism is it's a detergent. You're literally inhaling soap. So yeah, it makes sense it foams. It dissolves the membrane of the bacteria. But yeah, I think Colistin is a great example of a drug that's a good nebulized drug, but a pretty terrible systemic drug, unfortunately. So yeah, it's pretty well tolerated outside of, as you mentioned, when inhaled, some of the chest tightness. But comparatively, there's practically no such thing as a effective Colistin dose IV that's not toxic. So it's and it really doesn't have very good penetration into the lungs IV either. So really, this is a kind of example where actually nebulized may be the better route altogether for this drug.
And you'll see us use that in the hospital sometimes, nebulized. IV, like you say, we try it, but it's always wrought with problems. And then off-label, in very specific cases, we try not to do this because we don't want to burn out antibiotics that we'd prefer to use IV, but we will use ceftazidime and meropenem off-label in some cases when there's resistance issues or tolerance issues, or in this case, ceftazidime, for example, stenotrophomonas is killed by ceftazidime and not by these others. And so there may be specific reasons why we're reaching for these IV injected drugs. These can be a big problem. I've never, in my 10 years of being here, figured out a uniform way that they're processed in terms of insurance. Sometimes they're processed through DME, sometimes they're through the IV infusion companies. Sometimes oftentimes it's very difficult to get them covered. And so I just want to partner with Melissa, and I want to partner with our you guys as colleagues at SHAR and at Outpatient Pharmacy here and Shields, because the other thing that comes up with these ones that are off label is dispensing the sterile water and the saline that goes with it, and giving the instructions. That can be very very tricky to order, especially electronically. We'll put in the order for the drug electronically, and then we want to work with you to continue to troubleshoot our best ways of ordering them, the saline vials that go with, the sterile water that goes with. Historically, we were using a pharmacy out of Georgia that was called Pharmaceutical Specialties, which was a CF specialty pharmacy, and they only did CF. Now they've been bought out by Maxor and IV Solutions, and so they will do some mail order stuff, but we got kind of spoiled because they were so CF oriented and we only had them to use, so they took care of a lot of the details, and we didn't specifically write out stuff. And so now that we're partnering more with you guys, we want to streamline and maybe get protocols, and we can talk offline about what diluents, what's the right word, diluents we want to use, and how they come, because you guys may be getting sizes that don't correspond with what we're recommending.
And just to kind of piggyback off of that, again, I know more discussion may follow offline, but what was very helpful for the pharmaceutical specialties was that I partnered with them, and we basically had created a cheat sheet. And essentially it said, so when we did order the colistin and the ceftazidime, basically there was like a one-liner that said, please dispense supplies. So it was inclusive that the syringe, the needle, and then essentially the sterile water were all kind of incorporated in that one prescription, just because, who the heck, going, I know sometimes Epic, you want it to be your best friend, but as Zoe and I learned last month in December that it's not our best friend. So I know Zoe, I appreciate her diligence in trying to work with the Epic folks in terms of just trying to add things to kind of make our lives a little more simple. But that's also something that, again, that we can kind of further discuss later on, just to see what, would make your life easier and mine as well. And that way the patients just get their meds faster. So
maybe what we can do after this call as a follow-up is I have this in a Word document form. And I would love to sort of update it and spruce it up in terms of, are we doing, what we recommending in terms of mixing and diluents, all of that, is that the best practice at this time, et cetera. So we can circulate that around and maybe come up with a document that we all feel comfortable with.
Dr. Brown, this is Miriam. And yeah, I agree with that. That would be awesome. But Zoe and I, we've been working with Fong from the Epic team. So it's work in progress. And I'm sorry, it's kind of out of my hands. And I know we're going back and forth at times, but we're working on it.
No, we really appreciate it. I mean, this is, again, a new partnership that, an opportunity for us to kind of make new protocols. So this is stuff that's been kind of on our books for years, and it probably needs some updating. So this is a good opportunity.
Yeah, thank you guys. Because then also I think we've experienced problems with Epic, even with our trying to create a patient simple schedule. You'd think it would be expeditious, but with COVID, I think that as we all know, that takes priority in terms of medications or order sets or whatever it may be. So work in progress for sure.
And these are some more things that just for completion that sometimes we use this in CF and sometimes we're using them in our lung transplant population. So our antifungal inhaled antibiotics, we've got the 2 lipid complexes, Ambisome and Abelset, that patients are usually on if they're on inhaled amphotericin at home. Because of the shelf life, they usually get a lipid-based formulation. In the hospital, historically, we've used non-liposomal or non-lipid-based formulation, but occasionally we have shortages. I don't know if we're still in a shortage now where we move up and we use the other formulations. But these we got to watch renal function. And these I have personally screwed up in the dosing of patients sometimes, and I've also caught people at home taking them too much. So this is when we circulate it around, I'd love some comments on this section as well to make sure that these are, that we all agree with the appropriate dosing here. The next one is actually FDA approved ARIKAYCE. This is our, and we are using this for mycobacterial, it's either MAC or Mycobacterium abscessus infections, and that can be in CF and non-CF bronchiectasis. And unfortunately, we just diagnosed one of our lung transplant patients who's going to come into the hospital, David, tomorrow for induction therapy for abscessus. And so we'll be using ARIKAYCE in that situation as well. But liposomal amikacin, that's the amikacin. Usually I find that tobramycin is the best inhaled or IV aminoglycoside to use in CF when it comes to Pseudomonas. The amikacin really is more of a mycobacterial drug. And so this is just to let you know it's available and it's nicely packaged. I think it uses a Lamira nebulizer system, which is I think the same eFlow technology that we talked about with the Caiston. And so this is not something we carry in the hospital, very specialty outpatient use. I don't know, Shields, are you guys able to provide ARIKAYCE at this time? Or maybe we have to look into it.
Yeah, I'm not sure what the operation side's able to do, unfortunately. I'm on the clinical side. I haven't personally counseled any patients on that product. But in terms of contracts and what's available, unfortunately, I'm not privy of that.
Okay. The main thing that happens with this, patients lose their voice, and then there's cough. And then again, same thing, you got to watch renal function. If their creatinine starts to jump up, it's a once a day medicine, but we can play with that a little bit. The last one, vancomycin, we occasionally will use both inpatient and outpatient for MRSA. And I know they've been working on getting an FDA approved vancomycin for years. And right now this is off label and very rarely used, but sometimes we do. And then for the last few minutes, I'm just going to totally change gears. This is something that you guys have been very helpful with us, which are the modulators. And just wanted to point out that there are 4 modulators on the market. And what does a modulator mean? Remember how we talked about the CFTR is the chloride channel that doesn't work well in CF. That is a protein, and when the protein doesn't fold correctly, doesn't move to the right place, that's why it doesn't hydrate and send the chloride channels. So all these medicines are they target the protein that is made, if there is some made, and they try to make it work better. And whether in the original, the first modulator was Kalydeco or ivacaftor, and then we had Orkambi, which was lumacaftor, ivacaftor, and then we had tezacaftor, ivacaftor, and now we have Trikafta, elexacaftor, tezacaftor, ivacaftor, or ETI. In my mind, there is really no reason to use any of these older 3 now that Trikafta basically encompasses it encompasses all the patients that would have in the past been on any of those 3. Trikafta is only approved down to, actually the FDA, I think yesterday voted to extend down to age 6. I don't know if that's a formal labeling yet. Right now, the labeling is 12 and up for Trikafta, but it very soon will be 6 and up. And so I think these are just going to stick around in the pediatric population. Like Kalydeco right now is approved for 6 months and up. So these are just, until Trikafta gets their approval all the way down to the youngest age. That's why these are around. But you can see Trikafta here. It's 3 drugs in one. The morning pill is all 3 drugs together, and the evening pill is just ivacaftor, I believe. So the important thing here, must be taken with food for good absorption, as you guys know, and people should not mix and match their pills. There are dose adjustments. Michelle, our post-transplant nurse, is the master at all the dose adjustments that have to happen. We do have some post-transplant CF patients that are taking Trikafta because of the extra pulmonary benefits, the GI, the sinus benefits. And so when they're on Cresemba, when they're on diltiazem, when they're on voriconazole, posaconazole, any of those, that you've got to do these different dose adjustments. And so we've gotten really good at it, but I think that some of you guys have flagged us most recently on letermovir and Trikafta interaction that I didn't know about. So on the clinical pharmacy side, somebody caught that, and I appreciate it. This is just sort of the Cliff Notes version of the fancy trials that led to the approval of Trikafta. I would call this personally the single biggest breakthrough in CF that has ever happened. It has changed really changed the face of our clinic. And again, it's just got FDA approved in October of 2019. We had 6 people that were on it through an early access program a couple months earlier, but now we are like a year and a quarter into this, and what I can tell you is people are much healthier, and our hospital admissions have plummeted, especially though we still have some post-transplant hospital admissions, but those are transplant complications rather than pulmonary exacerbations. So these 3 taken in combination for people, the original approval was for people with 1 copy of Delta F508, at least 1 copy, and now they've expanded that a little bit. But basically, if a patient with CF makes a protein, then you can try to take this triple combo to make their protein work better. And that results in better lung function, easier weight gain, better symptoms, less cough and sputum, and better quality of life. And basically, you remember how we talked about lung function? We measure an FEV1% predicted, and 80% and higher is normal. This basically added, for people compared to placebo, 14% absolute improvement. So that's tremendous. And 5 to 6 pounds of weight gain in the first month, much better symptom control, quality of life, etc. I'm not gonna, for the purpose of time, these are the graphs that support that, basically. And then there is one really nice biomarker in CF, which is called the sweat chloride test. You guys probably know that's a diagnostic tool where you inject pilocarpine in the arm and you make people sweat and then measure how salty it is. What you can see, which is really cool in terms of a biomarker, with this triple combination, people on placebo still had that, maintain their baseline sweat chloride value over the course of the study. But when they were on the triple, it dropped 40, 45 points, almost to a level that would be below the threshold to make a diagnosis of CF. So that's a good biomarker to show, yes, that we are improving the function of the chloride channel at the protein level, and it's resulting in the symptom improvement, the weight gain, and the lung function, and also a decreased rate of getting sick. And that's critical because we know that the disease over time progresses because people get sick. So if we can stop that, we can stop progression of disease. Somebody in preparation for this call wanted us to just mention safety and sort of side effects with Trikafta. So this was most common adverse events looking at Trikafta versus placebo. So the most common was pulmonary exacerbations or infective pulmonary exacerbations, but it was 47% in placebo, 21%, so much less in ivacaftor. Increased sputum. At first, patients describe that they'll get more chloride function, and they'll describe what we call the purge, which is where everything even their sinuses get clear, their nose starts running, everything gets runny, and they'll cough up a lot more sputum at first, but the viscosity will be a lot thinner. And then after that, most patients settle down to the point where they barely even cough at all. Now we have a problem in clinic that we can't get sputum cultures because people can no longer cough up sputum on command. So Melissa usually throat swabs, which, to try to see what bacteria may be predominant in the respiratory tract. Headache, we have seen headache, especially at first. They list cough here, but again, cough was pretty much halved by the drug. I haven't heard about diarrhea. People have had some abdominal pain when they first start taking it. Remember, it's going to change their body, their chloride functions all over their body. So some people become initially more constipated, then their bowels improve with less bloating and gas. Other people, there's been an uptick in gallstone, symptomatic gallstones at first. I never say never, but generally we haven't had people have a hard time tolerating the medicine. And it's unlike Orkambi. Orkambi was the second modulator that was out there. It caused a lot of chest tightness. We don't see this at all. So it's very well tolerated. We have seen more acne. So both women and men with more acne. Usually patients feel so much better. They don't care about the acne. They just start topical treatment for their acne. Another thing that we should counsel patients on is women may become more fertile. Remember how we talked about thinning mucus all over the body? Some of the fertility issues that women have are due to thick cervical mucus. So we need to make sure to tell them when they start Trikafta. We try to do it in clinic, but if you guys are dispensing, that they could, that they need to have birth control method if they're sexually active, because they could, even if they've been sexually active, no birth control in the past, they might get more fertile. So something to think about. And then liver function tests. So that's the monitoring that we do is AST, ALT, and T-Billy. And there was, generally in the single digits, but 10.9%. Some of these are elevated, and we have not had to completely discontinue anyone, but we have had people up at 2 and 3 times the upper limit of normal for AST, ALT, and we work them up. And as long as they're stable and it's not worsening, we just watch them really carefully. The guidance is to check LFTs at baseline and then every 3 months for the first year. If people have pre-existing liver disease, which can happen with CF, or they have an abnormal value on one of their test results, then we watch them, then we check every month. Any questions on that? This is my second to last slide. What has Trikafta done for lung transplant? So we're in the business of lung transplant as well as CF, but we would love to be put out of business for lung transplant, and we might be soon here with in the CF world. So this is data from the UNOS, or the transplant registry, and this is the number of lung transplants that have been performed over the last 5 years. And in yellow here is the amount for CF. So historically, CF has been sort of 10 to 15%, 10 to 12% of all lung transplants in the United States were done for people with CF. And you can see that 11, 12, 11, 10, maybe something starting to happen here in 18 and 19. Remember that there were 3 modulators approved right up until this time, but this is when Trikafta came out, October of 19. And there were a large amount of people with advanced lung disease that got into an early access program. So, last 4 months of the year, people with advanced lung disease CF may have been on Trikafta. So maybe that's why it was only 9.1%. But you can see that only 3% of all transplants last year in the country were performed for CF. So there's clearly a statistically significant drop in those being, and it's not just transplanted, but if you look at the wait list additions, same thing. And of course, COVID hit, and we can see that overall, all the numbers went down, but this is disproportionately down. So we think that the Trikafta is going to result in less lung transplants, or at least pushing people to have lung transplants at an older age.
And I will give a shout out to Melanie and Gloria. So again, this drug was approved of in kind of middle to end of October of 2019. And when we came back from the CF conference, basically, I think they announced that it was approved of when we were at the conference. So we kind of came back guns a-blazing. And if it weren't for Melanie and Gloria, I wouldn't have been able to get as many patients on therapy as quickly. And I guess this is due to you all as pharmacists and, getting these drugs for the patients. And I will say that in terms of our data from last year, we are above national average in terms of prescribing and getting patients on therapy. So I think that's, you guys are a part of the multidisciplinary team. So I just wanted to essentially thank everybody for your hard work, because it truly takes a village. So.
Absolutely. And I think Melissa ran a registry query, and I think it's something like we're 69 out of our 85 or 90 people that qualify for Trikafta in our program are on drug. And the rest have been offered, drug, and maybe are post-transplant and they don't want to take it, or maybe are normal lung function, or maybe have cirrhosis and they're scared to get started. But we have very high Trikafta utilization rates, and I think it has really changed people's lives. So thank you for everyone involved in that. This is my summary slide. This goes back to, again, our I think I talked about the 4 tenets of care in CF: the nutrition, the lung function, respiratory, antimicrobial, modulation. Last one, lung transplant, may be playing a less of a role in the future for CF, which is a good thing. But I will just take a moment and say, as awesome as Trikafta is, there's still about 10% of CF patients that, because of their mutations, don't make a protein to fix. So the modulators, don't help them. So, and unfortunately, these 10% tend to be some of the more rare mutations, some of the underrepresented minorities, Hispanics, African Americans, NCF, people that may have a late diagnosis, may not be in the greatest shape to start with. So there will still be people needing lung transplant, and the CF community remains committed to finding pharmacologic therapy, or it probably is going to have to be at the gene or messenger RNA level to try to help this the last 10%. But with that, I will thank you guys for attending and look forward to continuing to work on this. I think most of us would agree it's a very gratifying disease to take care of, complicated, but gratifying, and it takes a village, and you're part of our village. So thank you.
Thanks for the wonderful presentation.
Yeah, thanks, Dr. Brown.
Good. Well, we'll follow up.
Dr. Brown.
We'll follow up. I'll circulate that the sheet, the antibiotic nebulized antibiotic sheet, so we can get comments.
Dr. Brown, would it be possible to also get a copy of your slides?
Absolutely.
Great. Thank you.
Yep. Thank you guys so much for your time and flexibility changing the date.
Thank
Thank
you.
you.
Thanks.
Yes, thanks, guys. We appreciate it.
All right, I'm going to stop sharing. Okay, cool. Have a good afternoon.